Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Now here's your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is attorney Adam Russo, CEO at the Phia Group. Adam, welcome to the show.
Thank you so much. It's an absolute pleasure to be here. Thank you.
So, Adam, before we get into the main part of the conversation, I always like to give my guest a chance to provide more of an introduction in terms of who they are and what they do. So, Adam, the floor is yours.
Well, I appreciate that. So I am the co-founder and CEO of the Phia Group, and we are a cost containment company that represents health plans to do everything possible to reduce the overall cost of care while actually improving quality outcomes. Basically our mission is that we feel that every person in this country deserves access to high quality, low cost healthcare. And what we see every single year is that premiums go up, deductibles go up, co-pays go up, and it's never ending. I mean, it's literally every year you can just do rinse and repeat and see the same thing. I started this company 25 years ago in my mother's basement in Quincy, Massachusetts. Total investment was $4,000. Today, we have close to 300 employees. Our main office is in Canton, Massachusetts. We have a large regional office in Louisville, Kentucky, and then employees in about 28 other states. And we represent roughly 20 million people with insurance across the country, most of it in self-funded health employer benefit plans.
It's a lot to unpack there. And before we start kind of pulling that apart, the other question I always like to find out about is what got you into healthcare in the first place?
So, I can give the short answer, the long one. I mean, it depends, right? But I always wanted to be an attorney. Excuse me. That I've known that since I was 12 years old. And it was based on the fact that my mom I was the firstborn in this country on either side of my family. My mother emigrated here from Poland. My dad came here from Sicily, and they were divorced when I was very young. But I always felt that because my mother lacked the speaking skills, the education, really understanding how the American system works. Remember, she came from a communist country, right? Where you waited 4 hours for a loaf of bread. Like, I'm not kidding. So at a very young age, I saw that she had a very hard time navigating the legal system, the court system, whether it's child support payments, visitation rights, all that stuff that ties into, probate and family law. So I felt at a very young age that I wanted to protect and take care of people like my mom that was in her situation. So when I was in college, I just wanted to get a job working at a law firm just to see what it's like, right? I didn't really care how much money it was. So my freshman year in college, I went to the co-op office, and I think I was getting paid like $5 an hour. It was a part-time, admin role at a local law firm. And when I got there, the owner of the company actually was an ERISA attorney whose brother owned a third-party administrator offering health benefits to employers. That's how I started learning about this business. And literally, I've done nothing else since the age of 18.
That's pretty impressive. And especially to fall into that area, that early on is, probably allowed you to see a lot of development and change within the industry. So it's, you were talking about, you work with self-funded plans, and then you're also talking about cost containment while trying to drive, quality improvement. So maybe just to help to set the table, when you're talking about a self-funded plan, what is that and how does it operate?
Okay, so what most people don't realize, even those that are in self-funded plans right now, 65% of employers offer their health insurance through a self-funded plan. 65% of all plans are self-funded. What that means is the actual claims, the money spent, is paid for with a combination of employee contributions and employer contributions. So every bill, the actual money is paid for by the company. and their employees. It's not a premium the way you would think, when you purchase a fully insured plan. You pay a premium, and then if you have no claims, you pay the same premium. If you got $1 million in claims, you still pay the same premium. The risk is with the employer as it relates to the claims going up and down every week, every month, every quarter, every year.
So if the risk is with the employer in that situation, then as you were talking about trying to contain the cost, what are some of those or some strategies that employers have used in the past and might be trying to use to change going forward? Since, as you already mentioned, obviously cost keeps going up. So the containment piece hasn't necessarily done its job yet.
Oh, not at all. So I like to tell people, self-funding comes in 3 phases. What I call the GED phase, right? Like the high school graduation equivalent, which I would argue that 75% of all employers that are self-funded fall into that first category. Literally, intro to self-funding. Okay, it's their money being spent on claims, but the employer doesn't even realize that they can control what we pay, how we pay it, who we pay it to. They're not empowered at all. Or they don't realize, and their brokers aren't telling them that they actually can control costs and they can do things to manage their plans. So going back to your great point is, obviously not a lot is happening with cost containment because every year it keeps going up. Well, that's why 75% of employers, I don't even think realize they have the power to do many of these things. The second one is I would call the college graduate, right? Someone with a BA, where the employer does realize that they can design the plan for their employees and have different benefit offerings depending on what their employees may need, okay? The final one, the third type of self-funded plan, I call the PhD level, which is like my plan, my company, we're self-funded, and how we run it. What that means is you actually look at the claims data. You're actually looking at where your risk areas are. Are people going to the wrong facilities? Are they going to overpriced facilities where the quality isn't that great? Are they utilizing emergency rooms when they could be going to urgent care? Are they, purchasing branded prescription drugs because they see a commercial on TV when there's a generic available? Those are the high level, really into it, understand the good and bad and the good things and the pitfalls when it comes to self-funding, and have much more control and interest and involvement in how their plan is being handled.
So kind of thinking about that gradation, are there barriers beyond potentially just the time and the resources to being able to gain that deeper understanding? Is the system set up in a way where maybe there's forces in the industry attempting to keep people down at that GED level?
Of course. So here's what I can tell you, right, is that most companies, most employers have a broker, and a health insurance broker, that person, the brokerage firm they utilize or the person they utilize helps them with, with their health insurance, helps them with their property insurance, automobile insurance, all the, the 401ks, all these things. And what's happened over the course of the last 50 years is that employers assume that their brokers are doing everything in their power to benefit them, right? They're looking at all the cost containment options, all these things. But here's the problem. There is a division between a CFO and the HR department. A CFO looks at all the different things that you could do at a PhD level of self-funding and goes, wow, we do these things. We could drive the cost down. The HR department is going, man, that's a lot more work. Way more work. There is no easy button when it comes to self-funding at a higher level. So that's the main problem. Right now in this country, and I'm going to go back to my high school equivalent diploma. Most employers spend 1 hour a year, literally an hour, on their health plan with their employees. Here's your enrollment period. Here's the gold. Here's the silver. Here's the bronze package. Pick one of the 3. Here's the deductible. Here's the copay, etc. 1 hour a year. Now think about it. You're a self-funded employer. And let's say I'm the employee, right? Adam Russo, I'm the employee working there. So I'm given a 1 hour, I guess tutorial or whatever about my healthcare options for myself and my family, right? I hate the word dependents. I call it family members because that's what it is, right? The dependents of your family, which I think is interesting, why they came up with that word dependence in the first place, but it's another story. So for me, every year I get a review, an annual review, biannual review, self-assessment. I have to do training. I might have to be certified, recertified in order to get a raise. So let's say I'm making $100,000 a year. To get a 10% raise, which is literally $10,000, think about all the things you listeners have to do in order to get that 10% raise. And all the processes, the interviews, the reports you fill out, etc. For $10,000. That $10,000 is an expense on your profit and loss statement. It is by far the largest expense that any company has are their employees and paying their employees' salaries, etc. Yet, if I decide to have a knee surgery, let's say I need a knee replacement surgery, and I got XYZ, Blue Cross, Cigna, Aetna, it doesn't matter which one. I call them the BUCAs. And I have health insurance with a self-funded employer. Nobody realizes that I could have that surgery performed at least here in Massachusetts, 50 different places. How much do I know about the quality of the actual physician or surgeon performing the surgery? Very little. How much do I know about the quality of the actual facility itself? Very little. I could find more information about a toaster oven I want to buy for my house than I can about the surgeon and the facility that are actually performing the surgery on my body. That's just the quality piece. When you look at the cost side, people just look at, here's my copay and here's my deductible. No one's actually seeing what the overall bill is that my employer has to pay. I could be at one of 50 different places. The price range that my employer would pay for that bill will range from anywhere from $15,000 to $115,000, just depending on where I decide to go. So my employer makes me go through the ringer to get a $10,000 raise on my salary, yet they have no involvement, share no details, you're given no incentives to look at cost, look at quality, and I could spend $100,000 at a really bad facility for that surgery, or $20,000 at a really good place for that surgery, which is an $80,000 difference, which also goes on the expense side to the bottom line. Every single employer in this country, I'm going to say every, at least 95%, do nothing about the scenario I just gave. Their employees literally just, how did they decide? Their doctor told them to go there. Maybe they had a different surgery there. It's the closest one to their house. Maybe their family member works at the hospital. I mean, think about it. How much time and research you spend buying that toaster oven on Amazon versus how much time and research you spend picking out the pediatrician that's going to take care of your kids. That's the utter issue that we see every single day, is a lack of any consumerism when it comes to your healthcare choices.
Yeah, and I think, as you said, like the little amount of time that both the employer and the employee put into that just keep feeding into that, kind of that bad cycle. And for those of you just joining, I'm talking with Adam Russo from the Phia Group, talking about self-funded plans and how the system runs. And I guess picking up on the point you were just talking about, Adam, of the lack of time and attention and given to the detail and explanation around how to probably more effectively and efficiently utilize the healthcare resources. Does the employer have any obligation? Because it's to do a better job on that front. And it's I know, being on the legal side, we always talk about fiduciary duties, and I have enough understanding to be very dangerous in this area, where I hear fiduciary duty thrown around a lot for the employer, and that there have been changes in the law in the past few years that are increasing their exposure on that front. So is that an accurate kind of intro into how employer behavior can be changed?
So I would argue everything you're saying makes sense, and I could go through that and explain how that works. But I don't think the fiduciary obligation is scaring employers into caring more because they have a fiduciary duty to be prudent with planned assets is going to work. I haven't seen it work. And I can tell you right now that I've seen that thrown around all the time. The issue is going back to employers not realizing they actually have the power to tell their brokers and to dictate and to mandate that we do something to lower the overall cost. Here's an example. We're a self-funded plan. We look at our claims data. Now, remember, no PHI. I don't need anyone's PHI. I just need raw claims data. We look at our raw claims data every single month, which tells us the behavior of the population that we're offering benefits to. So we'll see, wow, we got a bunch of people on a branded weight loss drug, Ozempic, Wegovy, when there's a generic semaglutide available. So what could you do? You can literally redesign the health plan to incentivize employees and their family members to use a generic. Here's an example. We'll waive the copay if you use the generic. We're not going to force you, but we'll waive it as just one. They look at the data. Wait a second. Why are all these people using the emergency room for these procedures? They could have just went to urgent care. Much different price point. Different price point overall bill. Different price point from a copay perspective. How about incentivizing people on the plan to care about the cost and quality? I'm going to give you one example that we do. So we know that in Eastern Massachusetts, there are plenty of places that a woman could go to deliver a child, have a baby. How do people decide where to go? I remember when I have 4 kids. There's not even one that's a preteen yet, so I'm very well versed in this. How do people decide where to have their baby? Well, my wife and I just listened to her doctor. Her doctor said, go to Brigham and Women. That's where I deliver babies. I have no idea if Brigham and Women is the best place to go for maternity care. Where would I even find that information? And the reality is, in Eastern Massachusetts, on a network plan, the cost to deliver a baby is anywhere from $12,000 to $75,000, depending on which hospital you go to. The same ugly kid is coming. It doesn't matter which hospital you use. But I can also tell you, people would assume the $75,000 price tag means it's a better facility, higher quality. That is not the case. It's not like buying a car where you assume an Audi is better than a Chevy because the price point's higher. It doesn't work that way. People just don't know. So what we did about 15 years ago, sorry, my friend, about 15 years ago, we realized our company was getting older, right? People started going to their 30s. They're getting married. They're having families. So we looked at the claims and we're like, we couldn't believe the price disparity. So what did we do? We looked at all the hospitals, and then we also created our own quality metrics, which, by the way, is not hard to do. We've built our own algorithms using AI, et cetera. And we identified the 3 highest quality facilities with the lowest price point. And we tell our employees, their family members, you can go to any in-network hospital, no problem. However, if you choose one of these 3, we'll pay for your diapers and your baby wipes for a year. The Boston Globe did a front page story about how innovative that was. I'm like, how is that innovation? It's consumerism. It's what you do every day and every other thing that you buy in your life. And it's not like it's an emergency, like you know ahead of time you're gonna have a baby. We've had 76 children born since we put that in place. All 76 parents chose one of the 3 facilities just to get free diapers and wipes. We have saved our plan over $2.5 million by just doing that. That's it. And nobody does it. People don't realize, as an example, that South Shore Hospital may be the highest quality for a certain procedure at a low price, and that the one down the street, let's say Beth Israel, isn't as good for that particular procedure, and it's at a much higher price point. Incentivizing the employees to care about the cost is the biggest thing that you can do. Going back to your original question about fiduciary duty, remember, you have to be reasonable and do what's prudent. If every single broker is just doing the same old thing every year, okay, this year your premium will go up by 12%. Here's what we can do. We can increase the copay, increase the deductible, cut back some benefits. That's what everyone does. So you're just following the reasonable man standard by just doing what everyone else is doing. The reality is, as an attorney, I have a law practice. We have an IOTA account. If I was 10 cents off on my billing of the account, I would have to go in front of the board of bar overseers, right? They could do an inquiry, literally being $5 off in client funds, because those are client funds. Makes sense. Yet, when it comes to health insurance, all of this falls under ERISA. I could have a $500,000 bill and pay that bill at 100% of the bill charge, $500,000. No one blinks. It's waste. I'm not calling it fraud because fraud is intentional. But the reality is that we negotiate claims all day. So we design benefit plans. We scrub claims. We do analytics. We identify overpayments. We identify claims that shouldn't have been paid. We negotiate out-of-network claims. The industry average right now on out-of-network claims, those are claims like when you go on vacation. For example, you go to Disney. Your kid gets hurt, knock on wood, and you have to go to Orlando Regional Medical Center. Orlando Regional Medical Center is an out-of-network provider. The average discount on out-of-network claims is about 25% off the bill charge nationally. So you're paying, an employer is paying $75,000 on that $100,000 bill. We average 76% off bill charge. That same bill we're paying, signed off on, for 24 grand. That's just one claim. And there are hundreds of thousands or millions of claims like this that no one is doing anything about. Why? Auto adjudication. It's not the administrator's money. Think about it. The insurance company is using your money to pay the bills. What incentive do they have to care about how much or how little you actually pay? It's not their money. That's where employers need to get to that PhD level and realize, sure, I could scare them with fiduciary duties and all that, but here's the reality. In every single lawsuit that I have seen over the past 25 years of running my company, for example, the state of California, there was a big case with Multiplan, I believe, where there was triple or double or triple billing on anesthesia claims in Sutter Healthcare's hospital settings. I knew that case was going to be settled. And people go, how'd you know? Because in a deposition, if they asked the hospital, you guys double billed for anesthesia, why would you do that? Their answer would be, everyone does it. The entire country does this. You have an in-network claim, but we're going to bill the anesthesiologist as an out-of-network provider. And when the state of California sees that it's not just one hospital system, one type of claim, that it's actually a national pandemic, they don't want to go there. They don't want to touch that. All right, let's make a deal. The fact is, with Wegovy, as an example, literally, we design plans, we see the schedule of benefits. Everyone is on a weight loss drug. I get everyone, we all know someone who's been on one of these, right? Wegovy costs on average $12,000 a year. The same exact ingredient, which is semaglutide 1, on a generic level, can be paid for at approximately maximum $2,000 a year. The only difference is Wegovy comes with a preset pen that you just open it, you pinch yourself, you're done. With the semaglutide, you actually have to fill the syringe with the liquid. That's the only difference. It's a $10,000 per year cost differential. Yet, who knows that you could have a generic, because they don't see generic commercials. They see Ozempic commercials, Wegovy commercials. So the problem with using the fiduciary argument is that everyone is doing the exact same thing. So the prudent man, the reasonable man standard really is hard to push against, because you could say that I hire a broker. I pay this broker a lot of money to tell me how to run my health plan. Obviously, they're the experts. I filled my fiduciary duty because I have an RFP process every 3 years. So that's the ultimate issue, that the roadblock that we face is just getting people to be educated enough to know, hey, it's your money. The data is there. Look at your data, and then your data will tell you what risks you have, what exposure you have, and then design an actual health plan to treat the needs of your employee population. Nobody does that.
Yeah, no, and I think as you ran through it, it underscores so many of the biggest, big problems, and just the arguably, easy path where we just let it run how it's always been running. But Adam, believe it or not, we're already almost out of time. So I'm going to ask you kind of one parting question, which is, if you could offer, the one word of advice to companies, what would you want people to take away with to start them on the path to enlightenment?
Realize that you can be empowered to change your plan. You have the ability and the right, since you're a self-funded employer who's paying the medical claims. Ask for the claims data. Require your broker to analyze the raw data and to tell you, hey, where is our plan falling short? Where are our largest risk areas? What percentage of our employee and dependent family population, are obese, have diabetes, potentially become diabetic? And realize that no different than your employee salaries, you can have some power and some control into how those funds are spent. The saddest fact is this: a plan of school teachers, or a plan of truck drivers, or a plan of yoga instructors, those three plans should not be exactly the same plan designs, because they each have their own unique needs. Yet, if you look at the overall population, all three of those plans will have the exact same plan design, the exact same copay structure, the exact same cost share, and they are run the same exact way by the administrator, even though each one of those plans and those organizations has a totally different demographic behind it. And what I try to tell people is, you're unique.
Yeah, no, great parting point. And thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.